it means so much to me to be standing with the inspiration of Dr. Stambaugh. The fact that he himself underwent a heart transplant, and the fact that he himself knew what aspects of medicine and healthcare mattered to him in what had to have been an ordeal, tells us so powerfully and kind of undeniably why it is that we're paying attention to the things we're paying attention to today. You know, he could have endowed, or his family could have endowed, a lectureship in immunology of heart transplants. But that was not what was felt to be the most salient part of his work. I've been here a day and a half at U of L and feel an electric charge at what it is you have the capacity to do here. It is not just doctors and medical students who need to know something about ethics, humanism, and narrative in illness and health. You're fortunate to be at a university in which the School of Medicine, the School of Nursing, the School of Social Work, the English department, the philosophy department, the Women's Center, the Women's Studies Center, and the law school are all urgently engaged in examining and taking on questions of illness. They may not have realized that's what they were doing, but indeed that's what they're doing. With, for example, the English department really committed to learning more and writing more and teaching more about such aspects of literary studies as bearing witness, mourning, loss, memory, understanding what happens when one person gives an account of himself to another. So there's something just fundamentally thrilling for those of you here in medical school or medical training, or really any of the clinical disciplines, to be at a place which needs you. Because as the literary scholars and the philosophers and the lawyers and the women's studies people try to learn about that which we do every day, well, they're going to come to us who do it every day and say, can you please teach me? So it's a very exciting time for this whole institution to be able to take on some of these questions which our patients require that we know more about. Sickness calls forth stories. Whether in the patient's chief complaint, the intern's case presentation, the family member's saga of surgery, or the coroner's death note, patients and health professionals recognize problems, gauge progress, and lament defeat, in part through telling about illness and having others listen. As we inspect the role of storytelling and bearing witness to narratives of illness in routine clinical practice, a specific instance of storytelling needs particularly close attention, and that's the practice of bioethics. I was invited here by those who work in the Ethics Institute and Division, and I think it's particularly interesting to think about ways in which narrative practice and being equal to the stories that we hear light up not only the practice of the nurse, the doctor, the social worker, the chaplain, but the ethicist too, who's often trained in health law and moral philosophy, and is attuned to or asked to adjudicate conflicts. And now within ethics, as well as within clinical medicine, what we are learning about narrativity has enabled us to enrich even the practice of the clinical ethicist toward, some of us call it narrative ethics, but toward enabling us to recognize not simply the ethical dilemma at the end of life or the quandaries that occur in the intensive care unit, but rather to recognize and give voice to all that the patient suffers, all that the family suffers, all that the healthcare professionals caring for that person near the end of his or her life suffers. And I go out of my way to mention medical ethics, but I could have gone out of my way to mention also the chaplains or the risk managers or the patient advocates. Indeed, many aspects of human services, exceeding even healthcare, realize that those who suffer must be recognized in order for their suffering to cease. And I include here groups of persons with whom we have worked. I run a program in narrative medicine at Columbia University, but we've been privileged to work with groups of students and faculty from the law school, the journalism school, the School of Social Work, pastoral care. And indeed, our practice is unified. Medicine, bioethics, nursing, social work, physical therapy, law, ministry, trauma testimony, and teaching. That's the beginning of a list of the professionals who do their best to respond to suffering by virtue of hearing and receiving accounts from those who suffer. The recognition that is required in the face of suffering requires first that the suffering person give an account of him or herself in either private or public ways. Doctor and patient, analyst and analysand, lawyer and client, domestic violence therapist and abused woman, tell and listen in private, whereas Holocaust survivors giving, for example, testimony in archives, or trauma survivors testifying at Truth and Reconciliation hearings in South Africa do so in public. Both the telling and the listening of accounts of suffering are extraordinarily complex things. It is not easy for persons who have suffered to tell of it. As you know well, an analysis will usually take 8 or 10 years, or 6 or 8 if you're particularly well integrated to begin with. The rape survivor often cannot tell of it, sometimes for years, as you know. I had an elderly patient who could never tell me enough about the back pain and the dizziness and the migraines and the joint pains and the belly pains and the trouble sleeping and the nerves and I was her internist for 18 years. She was by then 89 years old, until she told me that yes, she had always been a sickly girl, but no, she didn't fall off a horse the way she told me she had. Rather, when she was 12, she was raped by the white boy on the next farm, she, a black girl, working granddaughter of a freed slave. That's what happened. She couldn't tell anybody at age 12 that she had been raped by the white boy next door, because she knew if she told her mom and her dad that her dad would seek vengeance and he too would die. Do you see? But the point is, it took her 18 years to be able to tell me, or frankly anyone, that she had been raped as a girl in the South. So I'm not coming to you with the news that these are easy things to tell. And oftentimes they're not remembered, and oftentimes they're only enacted. These are most complicated forms of tellings imaginable. I want to pay attention to the complexity of the listening of accounts of suffering told by the sufferer. Telling requires skill and commitment. The listener must be poised to be the receiver of that which is told. Whether physical therapist, chaplain, or special education teacher, this listener recognizes the patient, penitent, or student who gives an account of self. That listener must absorb, interpret, and honor that which is told. These accounts of oneself are not necessarily only told in spoken or written language. You remember that there are some situations, autism, the extremities of trauma, coma, where language is not available to the person, and such accounts are given performatively, either in artistic media. Many of those with autism are able to express themselves in non-language, or corporeally, by virtue of the very body, by the presence and singularity of that body. So that in instances of illness, which includes all of us in this room, the listener, the receiver, has to be receptive in a great number of ways, able to absorb and interpret that which is emitted by the sufferer, not only in language, but in silence, in gesture, sometimes really in physical findings. So that all of us, as we read EKGs and feel the liver edge and do the mini mental status exam, understand, or must understand, that not only are we accruing clinically salient data that can help us in diagnosis and management, but that we are also accruing personally salient data about the suffering that is being undergone. As we notice the unity of our different practices of easing suffering through recognizing the teller who suffers, and I'm talking again about the way that the doctor, the nurse, the social worker, the teacher, the cop, I do a lot of work with police officers, the domestic violence counselor, that as we realize how we're all doing sort of the same things in our different settings, we realize not only the unity of practice, but also the unity of suffering. The cohesion or the overlap among these different practices simplifies and complicates suffering by muting the technical aspects of any form of suffering. Disease, legal trouble, marital trouble, learning disability, loss of faith. These are all troubles from which one can suffer. So by thinking of our practice in what it shares, we're muting the technical aspects and we're amplifying the interior aspects or the fundamental aspects or the profound aspects of suffering. This muting and amplifying makes audible these deepest levels of what the sufferer endures. The sufferer may endure a heart attack. The sufferer may be one of my police rookies on the street who is fearful of getting shot. Do you see? They are both enduring the suffering of facing death. My patient with multiple sclerosis and somebody facing bankruptcy are both enduring the kind of suffering which one has when one is out of control. Do you see? So there are really not all that many forms of suffering. Being out of control, facing death, being abandoned, not mattering, being lost, bearing pain, and not being able to prevent the pain of those we love. These are the forms of suffering. And whether you've gone blind, whether you've lost your faith, whether you've lived through Hurricane Katrina, whether you're in a divorce, or whether you end up in foster care, do you see? You're profoundly suffering from one of these kind of elemental, primal sources of suffering. This is not to say that the technical levels aren't important. I have to deal with the MI, and the minister has to deal with the loss of faith. But if I perceive the underlying kind of suffering, the profundity of suffering, I can even do more in order to not just accompany, but help the person who is suffering. What's wrong with medicine today is that it seems to have lost its diving bell. It responds superlatively to the coronary occlusion or the herniated disc, but it doesn't always recognize this underlying profound suffering of being abandoned or being lost or not being able to protect those we love. It's not always been the case that that's so. I think medicine knows how to do that. And yet there are ways in which we have lost the habit of doing not simply our technical requirements, but also responding to the profound suffering. I want to read you a chart entry from an office chart written in the early 1970s. This was written by my father, who was a GP who had his practice in Providence, Rhode Island, taking care of French-Canadian mill workers who lived in Providence. And when he died, I just took all his charts in great big file cabinets. I just took them. I'm sure it was illegal. I just took them. And I've got them, I read them, and it is only in reading his charts, written in his handwriting, that I finally know what on earth he was doing in that office all the time. And that I also now finally know why I've ended up trying to be the kind of doctor I'm trying to be. I want to read you an entry from one of his charts. He sees a 25-year-old married woman for the first time on August 23, 1973. And this is his handwriting. I delivered her 25 years ago, is the first line of the chart, with a notation of the name and address of the patient's mother. She has been, quote, sick 3 years, no medical care, separated 3 years from husband, afraid of doctors, very unhappy, away from husband who makes life very miserable for her. She yells at daughter for no reason. 160 over 100 with 3 exclamation points. Should have H-Door, which I think is hydrochlorothiazide, but I'm really not sure. Very anxious and depressed, was thinking of suicide. He sees her weekly in the office. starts her on an antidepressant and a diuretic. She's able to return to work. I think she was a sales lady in Shepherd's department store. She's able to return to work after 3 weeks. She continues to see him in the office regularly and consults him by telephone as well. And this is all recorded in the charts. And then with the date specifying only 1974, my mother, who worked as his receptionist in the office, writes in the chart, she sent us a Christmas card. So you see what happens there. And this wasn't that long ago. What my father does is to represent many aspects of his patient's suffering as unified. Her psychiatric disease, marital problems, hypertension, and trouble raising her daughter are unified within his act of representation. The frame he chooses is wide enough to include her mother and even my mother and our Christmas rituals. I think that it is in the representing act itself that he finds that unity. It is in the representing, perhaps, that he even finds the suffering. And I can say that because now many of us at Columbia have indeed been trying our best to represent the suffering that occurs in our practice. And not restricted to our own suffering, but the suffering that goes on. One way I started to learn about the power of the representing is you're always your own non-controlled experiment, right? So I want to read you something that I wrote about a patient of mine. An old man was dying. He had had a large stroke, leaving him partially paralyzed, with the ability to say only one word, the name of his wife. Sarah. Over and over he called out, Sarah, Sarah. This is all he could say. His rhythmic one-word lament told me, an inexperienced third-year medical student, all that he could not put into words. His lament conveyed to me that he was lost, that he felt alone, that he wanted to be with those who could recognize him, even in his altered state. Over the time that I helped take care of him, I grew to know his body very well. I examined him and drew his blood as tenderly as I could, slowly coming to know how not to hurt him. I think he came to recognize me, or at least my hands on his body. Sarah and her daughter were usually in his room, staunch in the face of their suffering, bereft even before his death by the loss of him. The night he died, I remember I was on call and I was often in his room. I remember very specifically how he was lying on his side and that he would wave his thin arms in front of his face and then curl them, palms outward, as if to shield himself from some unwanted visitor. In retrospect, I wondered if he had seen death coming for him, if he had known before the rest of us did that he was being taken away. I always wondered what he must have suffered having known. I remember that the next day our whole team had to go to his autopsy. The pathologist displayed my patient's organs in rectangular stainless steel pans. His shrunken kidneys, his baggy heart. I tried to hide my tears from my intern and resident, but how I wept to see him now so finely dead, so finely not alive. This man I had tried to care for, this man I had watched decline. The day after he died, his wife and daughter came to get his belongings from the hospital. His daughter gave me a gift to thank me for taking care of her father, a little scarf that I've kept through many moves over the intervening decades. I behold it as a reminder of him and all that he and his family taught me about grief and about death and about love. But I read you that now to say, I wrote that about 2 years ago. And it was only as I wrote this description of something that happened 27 years ago that I experienced my acute sadness and mournfulness and grief. I wept as I typed, not re-experiencing a loss, but experiencing it. That's what I mean. That it is indeed in the act of representation that we are able to experience, to undergo that which, before we represent it, might be something horrible or painful or chaotic, but it's formless. And the human equipment is such that before we can experience something and metabolize it, we need to in some way give it form. We need to be able to examine something whole. So when I say, I think perhaps my father recognized the suffering by virtue of how he wrote his charts, I mean that. That it was in the run-on sentences with the dashes between the marital troubles and the yelling at the daughter and the suicidality that he was able to grasp the fact that they were united. So in many, many parts of the hospital now, we have gathered doctors, nurses, social workers, chaplains, students, fellows, whoever wants to come, to writing seminars. We have writing courses. I'm the writing coach. It's very swell. I'm the writing coach. And one place we have such writing is in the adult inpatient oncology unit, the floor, the unit in the hospital where adult cancer patients are admitted. And at a place like Columbia, they're very, very sick cancer patients. I mean, the ones who get better quickly don't come to us. We get the ones, and I'm sure it's true here too, we care for the patients who have failed ordinary treatment elsewhere. So you can imagine the level of defeat and loss that is experienced by these healthcare professionals. They came to me some time ago saying, maybe that thing you do with the writing can help those of us who do this work day in, day out. Too many nurses are quitting. You know, they work in oncology for 2 years and then they take a slot in the ER. We're not doing well. So we started writing seminars. There was one incident. There was a death of a pregnant woman who had a brain tumor, and she died, and the fetus died. And the day after the death, the medical resident just doesn't show up. And they find her, and they say, you know, and she says, I can't do this. She didn't end up quitting medicine, in fact, but there was a period of time that she couldn't come in, and she just said, I can't do this. So it was that incident that led the oncology service to know they had to do better in addressing the suffering of their own workers. So we've been meeting twice a month for a couple of years now. And it's the first time that we've found a way under these technical concerns that otherwise separate us. If U of L is anything like other hospitals that I know of, there's friction between nurses and doctors, between doctors and social workers. There's friction. These places are very fractious places because we all have an idea of what's to be done and who's to do it and who's in charge and things like that. The practice of writing, of trying to represent what we see patients going through and what we ourselves go through, is a way to get under the fractious divides, because all of us are doing our best to recognize the profound, the being abandoned, the being lost aspects of the suffering. And so over time, these oncology nurses, doctors, social workers not only have gotten to be better writers, but by virtue of developing their skill as writers, as those who can represent that which they see, the better skill they are in attending to it to begin with and perceiving it to begin with. So when a nurse said to me, I knew as soon as I admitted that patient that I would write about her, I knew she wasn't being a hack writer looking for material. I knew what that meant is that by virtue of her developing skill in representing what goes on, she was more able to perceive the deep, moving aspects of suffering that she saw. But it is not the case in the ordinary way we deliver medical care that our patients have a chance to give an account of themselves, right? I mean, think of what happens when you see a new patient for the first time. You may be given a half hour instead of 15 minutes in the office. Say this is, in the office, in the outpatient. And you've got so many questions to ask the patient about their medical condition and their prior illnesses and their surgeries and their diet and their exercise and their allergies and their medicines and all of that, that you end up sort of firing lots of questions at a patient, or maybe even giving it to her in a checklist beforehand, that you don't have the opportunity to just say, I'm here to receive the account of your suffering. So I started doing some experiments in my own practice. I'm a general internist. And instead of going into the whole drill of asking all the questions, I said 2 sentences. I will be your doctor, and so I need to know a great deal about your body and your health and your life. Please tell me what you think I should know about your situation. And I've learned that those sentences act as an invitation to a person to give an account of their suffering. And so I trained myself not to talk anymore, not to write, not to type on the keyboard, but really to absorb the account given. And I pay attention to how it's given. What does the patient consider is the beginning of their troubles? What aspects of home or work or life or school or children or parents or emotions will I hear along with the knee pain or the chest pain or the trouble breathing? And I end up with these very, very valuable utterances. I don't tape record them because I think that would be intrusive. But you can imagine the power of this account of illness framed by the patient no matter how they want to frame them. And these accounts often establish the foundation of our work together. So that, for example, one guy who had he had open heart surgery. He had critical coronary disease. He had bypass surgery. During the perioperative time, he had a big stroke. So his heart was okay, but he had a big stroke. And rehab didn't help very much. And he was left with a dense hemiparesis and a great diminishment in his power. He couldn't walk, he needed a wheelchair, he had lost his job, he lost his apartment because the doors weren't big enough for the wheelchair. Tremendous losses. And when I met him for the first time and listened to his account, it became clear that one of the most acute losses for him was independence. And if only he could get out of the house without some home attendant pushing his wheelchair, that might help a lot. So the first thing I did as the general internist after seeing this guy was to order up a motorized wheelchair. I would otherwise have gotten to that maybe 6 months down the road. Do you see what I mean? It just, if you're working off or working with the account of suffering given by a person, then you know where to start. It's sort of very simple. But it does other things too. I'm beginning to see what happens by virtue of eliciting and attending to the accounts given by others of their suffering. And also within this, my team and I are trying really to understand very clearly why it is that representing these accounts of suffering matter so much. What I do in the office is, when the patient is changing into a gown so I can do the physical exam, I write down their account as accurately as I can. I transcribe what I heard in their words, in the order in which they said it. I don't sanitize it into a medical note. And then when the visit's over, I give the patient a copy of this, either a computer printout or my own handwriting, and then that's like the footprints of where we started and what we do. And from then on, my patients accrue their own charts, because everything I write about them I give copies of. They often then bring me things they've written about what they're going through, so that they end up with their own independent, the patient should be the curator, it seems to me, of what's written about them. But you see that the simple change in routine really affects the whole work together, including who gets power over the written word. But as we're trying to figure out why does this matter and how can we become dutiful listeners to these accounts, we've turned to work in literary studies, in autobiography theory, and in philosophy, especially of Hegel and Emmanuel Levinas, to understand how better to honor these accounts given by others. I want to start with just a few citations from a work by Judith Butler, who's a philosopher and literary scholar, called Giving an Account of Oneself. First of all, she reminds her reader that an account of oneself is always given to another, whether conjured or existing, and this other establishes the scene of address as a primary ethical relation. This is to say, there are two people in the room, and the two people in the room matter. Dory Laub, who's a psychiatrist and Holocaust survivor, who co-founded the Fortunoff Video Archive of Holocaust Studies at Yale, interviews Holocaust survivors on videotape and invites them to tell of their suffering. And many of them are now in their 90s, to tell of their suffering, in part to add to the archive and the historical record of what is known about the Holocaust. He says, this is in a book called Testimony, bearing witness to a trauma is, in fact, a process that includes the listener, the intimate and total presence of another. The survivors are talking to somebody they have been waiting for a long time. We don't realize, all of us, as doctors, nurses, social workers, health services workers, and even human services workers. We don't realize, all of us, the urgency and the depth of the gift that we give to our clients or patients by being willing to be that listener. We don't always understand that someone has been waiting for us for a long time. Once we accept the requirement for and the contribution of the singular listener, we pay attention to what that person undergoes in accounts of self given by others. Something happens to this listener in the course of telling and listening. Hegel's concept of reciprocity is helpful here. I read you a sentence from the Phenomenology of Spirit about self-consciousness. This action of the one has itself the double significance of being both its own action and the action of the other as well. Each sees the other do the same as it does. Each does itself what it demands of the other, and therefore also does what it does only insofar as the other does the same. All right? Which is to say, when I recognize a patient in the office by virtue of giving him a chance to give an account of himself, I am simultaneously recognized by him. Usually after these accounts in the office, we both sit in silence. Sometimes we take one another's hands. Sometimes there are embraces at the end of the office visit. I cannot see too many patients in a session in the office, not because I'm not efficient with my time, but that the experience of attending and listening for patients is simply too moving and grave to be hurried through. I have to sit silently in my office between visits to dwell on and honor what has just occurred. And that experience, I'm coming to learn, is shared by all these colleagues of mine, be they lawyers or journalists or teachers or rape crisis counselors. Judith Butler again says, I am invariably transformed by the encounters I undergo. Recognition becomes the process by which I become other than what I was, and so cease to be able to return to what I was. So do you see? Those of us who feel worn out, depleted, burnt out, all of that, through our clinical practice, are perhaps not making enough room for the extraordinary transformations possible through this reciprocal recognition. I mean, I'm sitting in my office every Thursday morning and I get recognized 10 or 12 times. And each act of recognition changes me, alters me, sees things in me that I didn't know was there. I don't return to the one I was before. Do you see? It's ecstatic, to use a word that Hegel likes. I don't think pre-meds, when they reserve their appointment to take the MCATs, know what they're getting into. Now, there's something special about the body. I'm going to close by talking as a general internist. There's something special about the body. When Emmanuel Levinas, who's a philosopher who realizes that his philosophy begins in ethics, that his philosophy doesn't begin in knowledge or being, but begins in ethics, he constitutes the philosophical position, the moral position, at the meeting with the other. He talks about the face and how when we are confronted with, when we are met with the face of another, that this meeting incurs duties in us, that the one who sees the face of another is by virtue of that meeting dutiful toward that other. But what interests me is that he chooses a part of the body to describe this. He doesn't say the person or the subject, he says the face, corporealizing this encounter. And I think that matters. I think that, I mean, no matter what kind of practice we're talking about, there always are inevitable references to the body of the person. But when illness is the center of the transaction, these things are very much heightened. The place of the actual material physical body in the things we do. There are things that my patients cannot tell me, but their bodies can tell me. It happens regularly that the body of my patient talks to me in ways that the patient doesn't understand at all. Through symptoms whose meanings the patient doesn't know. When I palpate a nodule in the thyroid, when I measure an enlarged liver, when I hear a bruit in a narrowed carotid artery, I am communing with the body of that patient and not, frankly, the patient herself. The fact that in my office practice, the physical examination follows upon the silently received account given by the patient matters, because I can, through touch, actually contact the body of that patient I have just heard. And reciprocally, of course, my body is touched in the process of the physical exam. So that when I listen for the murmurs of the heart through my stethoscope, it is as if I'm continuing my listening tasks, simply in a different register. But what this means then is that we in healthcare have all the more richness of things to listen for. I just feel so grateful that I became a general internist and not a kind of doctor who doesn't touch their patients. I mean, a lot of my practice feels like a psychoanalytic practice, but I couldn't be an analyst because then I wouldn't have the touchingness of the body in order to continue the work. Let me close by reading the first few lines of a short story written by Eudora Welty. I hope you know Eudora Welty. She's a Southern novelist. She was born in the early part of the 20th century. She died recently. She's the one in her autobiography who said, "Long before I wrote stories, I listened for stories. Listening for them is something more acute than listening to them. I suppose it's an early form of participation in what goes on." And as I'm talking about the listening that occurs in the office through words as well as through bruits and everything else that we hear of our patients in their suffering, this short story comes to mind. I happen to have taught it in the certificate program in ethics and humanities just a few weeks ago. I taught the story called A Worn Path. So I will read you the first little bit of A Worn Path by Eudora Welty. It was December, a bright frozen day in the early morning. Far out in the country, there was an old Negro woman with her head tied in a red rag, coming along the path through the pine woods. Her name was Phoenix Jackson. She was very old and small, and she walked slowly in the dark pine shadows, moving a little from side to side in her steps with the balanced heaviness and lightness of a pendulum in a grandfather clock. She carried a thin, small cane made from an umbrella, and with this she kept tapping the frozen earth in front of her. This made a grave and persistent noise in the still air, that seemed meditative, like the chirping of a solitary little bird. Now, by the end of this very short story, I think it's 3.5 or 4 pages long, the reader is brought into the presence and frame of mind and worldview of Phoenix Jackson, aware of her habits and strengths, her knowledge of the country and its inhabitants, her attention to her ill little boy at home. Eudora Welty brings us the rich, evocative reality of this old woman's life, the teller decidedly on the character's side, trying her best to let the reader peer inside the heart of the story and the heart of the woman. And I found myself telling my ethics students, and these are doctors, nurses, lawyers, judges, risk managers, and the like, who do ethics consultations and who are on the ethics committee, I ended up saying to them, this is your task as the ethicist. And I could have said to my medical students or my nursing students or my fellows, this is your task as a doctor, as a nurse, as a chaplain. You are to recognize your patient and then to represent her with the attention and the detail and the fidelity that Eudora Welty represents Phoenix Jackson. Your reader, whether it's the ethics committee or the intern or the surgeon who's going to operate on your patient, will realize that you have done your humble best to bring the full reality of this patient into view, not only his or her illness, but his or herself. And this indeed is this task of recognizing that I've been brooding about with you for the hour. I think this is our task as ethicists, as healthcare professionals, as human services workers, as those who have others in our lives. And it is only through stories that we can fulfill it. And I thank you very much for your attention. Yes. The question is, but it took the 89-year-old woman, 70 years to be, or more than that, 75, to be able to say something about her trauma and her suffering. And indeed, and so your question is sort of, is there a way to speed that up? Or are there other things other than words? Yes. Well, I think that that's one of the cautionary tales to myself. As I realized that, I said, it shouldn't have taken 18 years. Would there have been something I could have done to enable her to come to this earlier? And I mean, that was one of the things I think that led me to just abandon the old clinical routine. Had I said to her, I will be your doctor, please tell me what you think I should know about your situation, it might at least have signaled to her that I was ready to listen to anything she wanted to say. So I think that's very much part of the motivating here, is that sometimes it just takes too darn long for us to get to the point that we can hear those things that really matter. And I think we have to go out of our way to signal, even if we're just the internist or whatever, to signal, I have the courage to listen to whatever you have to say.
Do you ever have any resistance from either, clinic directors, from colleagues, from your learners, from your medical students and residents, and from patients themselves, who are saying, I don't want to talk about this, I just want to tell you I got a sore throat?
Right. Sure, there's a time for everything.
Because there's got to be some
Right.
disturbance at times. With
Right.
cognitive
Right. And indeed, you know.
Again, synopsize this is on the website.
David wants to know, are there some times that either the healthcare professional or the patient says, come on, let's just get the work done? And indeed, there are times that there can be long stretches of time where the transactions are highly technical, highly specific. We need to get a stress valve, we need to get cholesterol down, we need to, whatever the case may be. Long stretches of time, sort of punctuated by a visit where there is this deep, rich account. All right? And indeed, Barry Gerlin, who's the head of gerontology at Columbia, asked me a very smart question. He said, what percentage of the patients in a doctor's practice would have to be written about in order for there to be a carryover effect to the whole practice? That's a very interesting researcher's question, right? I don't write this way about all my patients, but not by a long shot. I may do so, you know, I don't know if it's 1% or maybe as much as 5%, but certainly not 80 or 90. And yet, the outcomes redound to them all. Because by writing about my 89-year-old from the South, I'm then more attentive to begin with, whether or not I write something down about those who come next. And so these carry over, these become part of the equipment. You know, we did one study where we took 100 medical students, we randomly assigned them to 2 different groups, a control group and an experimental group who did some writing with me 5 times. It was once a week for 5 times. And there were statistically significant differences in the groups in terms of at least what the faculty rated as their interviewing skills and their therapeutic relationships with patients and their abilities even to do procedures. Now, I've not gone back to these third-year medical students 2 years hence to see if there's any ongoing, because I don't think 5 weeks is enough. But you see my point, that there may indeed be sequelae, consequences of increasing these narrative skills over the long haul.